Okay. Do you want to?
Dr. Srinivasan,
Yeah.
yes, there are certain people who initially do the latissimus dorsi muscle transfer, wait for some time, and then they go in for the implant. What is your opinion on that? Something like a
If
two-stage. People say that it expands chest also a little bit.
I think it depends on what is the skin that you need, skin pattern. If like in this lady, she has a good quality skin. So what you need is perhaps again in this lady not examined, but it looks as though her pec major essentially is intact. But in cases where pec major sternocostal part is absent or the skin is quite tight, then we can, in single stage, put an LD to bring the muscle and recreate the anterior axillary fold and have a tissue expander beneath that, maybe. But if the skin is quite tight, maybe it is best to do a tissue expander first, stretch the skin, and then do a muscle transfer at a second stage, do the other way around. Let's not forget the importance of skin. You need a good quality, pliable skin for a good reconstruction in the end, whichever technique we do, be it a fat transfer or a LD muscle. We need a skin quality to be good. Dr. Leti, you want to continue?
Yes, sir. Yes, sir. So, coming to the operative technique, after the informed consent under general anesthesia, under loop magnification, I would like to place the patient in lateral position and mark. So, the marking is done on a cadaver. We'll mark the midline, and the base of the implant that we're going to place will depend on the base of the breast on the opposite side. And also the implant should be at least 1 to 2 centimeters away from the midline or the sternal margin, so as to prevent symastia. Then after that, we mark the LD. The LD is marked with, sir, the incision I would like to give will be in the posterior axillary line near the closer to the axilla. So as to have a hidden scar line. For the marking of the latissimus dorsi proper, first the midline is marked and the tip of the scapula and the iliac crest. The muscle is between the below the tip of the scapula and between the posterior axillary line and the midline. So and the pedicle will come from the thoracodorsal artery is the pedicle which it is based on. So it will be about 1.5 centimeters posterior to the posterior axillary line. Then I would like to go ahead with the steps of surgery. After the initial infiltration along the markings, the incision is made in the posterior axillary line about 1 to 2 centimeters from the anterior border of the latissimus dorsi. Then, sir, I would like to first create the pocket anteriorly and then go ahead with the latissimus dorsi muscle separation. The first we separate the muscle in the between the trapezius and the serratus muscle. Then the it is separated from the skin, and then after this the muscle is separated from the humerus, and the pedicle is dissected and the nerve is transected, and the flap is brought anteriorly with long threads. Sir, this long threads I would like to use as bolsters onto the chest wall so that the muscle stays in position. Underneath this, at the same setting, we can put an implant, or it can be done at a later date.
Dr. Reddy, 1 minute, 1 minute.
Yes.
You're
Yes.
talking about the incision on the back where you are raising the muscle. That is clear.
Yes, sir.
What's the incision you're going to use on the chest? Where?
So the in the axillary fold, I would like to give an incision and then dissect the pocket.
And how would you drape the muscle for the whole of the chest wall? And how would you fix it on the medial end, inferior end?
Sir, I would like to take long sutures.
Endoscopically?
Sorry, sir.
Endoscopic, or how would you visualize or fix it onto the medial end when you bring the muscle?
We can use the lighted, the illuminated retractors, but if endoscope is available, then we can use an endoscope also.
Okay. And when you say bolster suture, are you going to bring it outside?
Yes, sir.
On the surface of the skin?
Yes, sir.
Okay. Okay. Carry on, please.
Yes, sir. And once then the donor site is closed with closed with a drain. We would like to keep a drain, so the donor site is closed in layers with a drain. Then coming to the post-op management, at the donor site, I would like to give a pressure dressing, and the suture removal usually done on the 10th to the 14th day. The bolster sutures are also removed around 7 to 10 days, and the drain is removed when the drain output is less than 20 ml.
1 minute, talking about the LD. Is there
Yeah.
anything to reduce the serous collection in the LD donor site?
So there are various techniques that have been described. One is we can use fibrin glue, and a second would be uh, um, so serial suturing of the skin to the quilting sutures can be used over the donor area, so that will also prevent the seroma formation.
How does that do? How does it reduce it just by sticking the skin? How does it reduce the seroma
So
collection?
basically the lymphatics which are injured, so that leads to more seroma formation. So we are the quilting sutures will help in reducing the space, the potential space that is present, so that will act as a bolster in itself and prevent the seroma.
The other reason, you're right, the other reason is the shear between the skin and the raw area. You are preventing the shear forces, so that reduces the serous fluid collection.
Yes.
And therefore, in some centers, people just use quilt, not even use a drain for LD donor site. But that's up to you, individual practices. But you can, in say cases, if you put a good quilting sutures, you don't need a drain for the LD donor site. It reduces the hospital stay for the patient.
Yes.
Okay.
Yes.
Okay, go ahead.
Yes, sir. Then coming to the follow-up, tissue expansion can be done once or twice a week, and the implant exchange is done at when the opposite breast volume. I mean, to one patient achieves 17 to 18 years of age. The follow for the implant would be once a month for the first 6 months, and after that once in every yearly. And so coming to the complications, the flap complications can be the bleed, injury to the nerve, or injury to the pedicle. Seroma formation is commonly seen, and partial or complete flap loss, though rare, can happen. The other implant-related complications are there can be an implant migration or a nipple areola complex malposition, which we would like to treat later on. And the improper positioning of the inframammary fold can also occur. The implant might migrate downwards also, and there can be a breast size discrepancy which can be addressed with a opposite side mastopexy or a reduction mammoplasty.
Okay. Can I stop you there for a moment? Go to the
Yes.
previous slide. I know you finished your talk. Can we keep on the complication side of that?
Yes, sir.
The complication slide, please. Okay. You talked about the injury to nerve, injury to pedicle.
Yes, sir.
What type of the muscle you're transferring? So which pedicle is important for the LD?
So we are using the thoracodorsal vessels.
Yeah. So what type in the type of muscle classification? What type of muscle is this?
So it has a one dominant pedicle and multiple minor pedicles. So type 2, sir. But
Okay.
we can base it both on the dominant pedicle and also the minor pedicle. So as a turnover flap also we can use it based on the intercostal perforators.
Dr. Reddy, I consider that you would have probably read a lot more for the exam. So let me go back and revise that types, please, once again, because there were slight differences in what you're telling and what the actual muscle is. Do you want to remind yourself about the types?
Yes, sir. So type 1 would be one dominant pedicle.
Yeah.
Type 2 would be one dominant and
If you want to think about some examples for every type, that will help you to arrive at the right decision. I'm sure you know the answer. I'm trying to get it out of you.
yes.
So type 1, if you give me an example.
Um, so type 1 would be tensor fascia lata.
Single dominant.
Yes, sir.
Yeah.
Based
Okay.
on
So nothing else. That's the only vessel that will supply. So that's fine. I understand that.
yes,
Gracilis. What about gracilis? Go to type 2. Type 2 is?
um, So type 2 is one dominant and multiple minor pedicles.
Okay.
And
But the whole muscle cannot be transferred with the minor pedicle.
based on yes, sir. That is gracilis. Yes, sir.
Correct. So that's gracilis. Okay.
Yes,
What's
sir.
type 3?
Type 3 is two dominant pedicles. The gluteus muscles can be used.
So any one of the vessel will hold whole of the muscle.
Yes, sir.
Yeah, you're right. You're right.
And type 4 is multiple minor pedicles. That is sartorius. And type 5 would be LD. So sorry.
Correct. So type 5 is one dominant
And
and
multiple minor
secondary,
pedicles.
not minor,
Yes.
secondary pedicle. The primary and secondary pedicle, not minor pedicle.
Yes.
The naming of is important because minor pedicle will not be able to sustain the whole muscle. A secondary pedicle can sustain the whole muscle if you want to use them from the lumbar perforators. You can turn them down.
Yes.
So the whole muscle will be alive. So that's a secondary pedicle. So it's a type 5, not type 2.
Type 5. Yes. Sorry.
That allows you to transfer it to the front based on the thoracodorsal vessel
Yes.
as a single pedicle, correct?
Yes, sir.
Okay. You talked about partial complete flap loss.
Yes, sir.
So let's say if you're transferring it, dividing the thoracodorsal, will it completely then loss of muscle?
Yes, sir.
Okay.
Yes,
What
sir.
about the backflow from the serratus branches? Would it sustain
Um,
some of the muscle?
so, but we are raising it completely away from the. We will be completely raising it and basing it only on the thoracodorsal vessels.
Okay.
So, I.
Again, going back to the same classification, being a type 5, you either keep it
Yeah.
on one pedicle or the other pedicle, so the pedicle becomes important. That's correct. Okay. The one thing in related to want to ask about implant-related complication, you said implant can migrate downwards.
Yes, sir.
What's the common problem with implant migration? Is it upwards or downwards?
Usually upwards, because the zones of adherence are in the lower part. But there's because we are doing a pocket dissection, sometimes there can be a movement downwards also because of gravity.
As long as you keep the intramammary fold preserved,
Yes.
the implant should stay, it's not going to go down.
Yes, sir. It'll
Unless in developing a
complete
pocket,
lateral or upward migration.
quite common is upward migration, yeah?
Yes, sir.
Not inferior migration.
Yes, sir.
One final thing in this one, how would you avoid a breast size discrepancy during your operation? Can you do anything to reduce the differences in your implant selection?
Um, So one would be the preoperatively we measure, and intraoperatively, so we can make the patient like break the table so that it comes about 45 degrees and see for the symmetry, and then identify if it is smaller, then we can use it, change the size.
Dr. Radhakrishnan and Dr. Bave, I understand the expander sizers are not easily available in India. That may be one of the reasons for this answer. I understand that. Okay. So in where it is available, you can use a sizer, which is an expandable sizer,
Yes, sir.
and that will give you a much closer match to the contralateral breast. But in this lady, particularly because she has got a good sized breast on the other side, you may have to start right from the initial consultation. That will be very difficult to achieve a perfect match.
Yes, sir.
Preparation of the patient is as important as the technique that you're going to employ for them to have a realistic expectation. Yeah, because she has a good size and good volume on the contralateral breast. And I take it that she may not want anything done to that. Therefore, bringing the same match with an implant, you may have to use a large implant, or you may even have to consider additional measures like fat transfer later on.
Yes.
But getting a perfect size match will be a bit difficult in this lady. Dr. Bhawe?
Yes, I agree with that. In fact, we will have to give an option of fat transfer after the implant, maybe later, in order to achieve the droopiness the other side has. And in India, we see it very commonly that patients wouldn't want anything done to the other breast because that is the only breast with which the patient is going to feed the baby, and here that is held as most important function of the breast. So you will have to actually achieve the similar droopiness on the other side, and with implant alone it will not be possible, so you will also have to inform them about fat grafting. Another important thing I would like to point out, that when you begin the treatment of this patient, you have to make it very categorically clear that what we are going to give is a cosmetic improvement and reconstruction of the breast, which is not going to be functional, because this is one issue, especially among our illiterate patients, that they may think that the newly reconstructed breast can be used for breastfeeding, but this has to be made absolutely clear to the patient, and maybe take it down in writing, that because this patient is going to desire to marry later, and it usually creates lots of problems in our marital proposals.
Yes.
Unmuted. In one other cases, it brings back to the other issue.
Yes.
These right from the beginning of your consultation, it may be worthwhile to include some psychological counseling for this patient to understand, make them understand, both from the scarring point of view, function point of view, aesthetics point of view. There are expectations are very different from what the patient may think the surgery is going to deliver and what you as a professional can achieve. So as Dr. Bave just mentioned, there may be a big differences and they'll be difficult to bridge them. So it's better to start right from the initial consultation. They may think that you can achieve everything as a plastic surgeon. You are kind of next to God, you can achieve everything. You may be able to, but function is not something you can achieve. Aesthetics you can bring in. So you need to counsel them, prepare them carefully. That's important.
Yes.
Going back to one other question that you talked about, complication, you talked about hypertrophic scarring. How
Yes.
would you manage them, if at all, and what type of scarring you are to keep in mind about hypertrophic scarring?
Sure. I would start with pressure. One is the scar massage. I would start as soon as possible, and also the silicone gel sheets I would like to use, because that will both give silicone and the pressure over the scar. Um, and so the second question I did not understand.
No, that's one question about hypertrophic scarring is what I was saying.
Yes.
Would you expect any keloid scar in this lady?
So I would first find out about the keloid tendency, but my incision is going to be in the posterior axillary line, so I'm not expecting that area to form a keloid. So, but I would still like to know about the keloid tendency in the family, or if she has any other keloid tendency.
Okay. Dr. Bowe, in this case, should we continue a little bit more discussion about Poland's in relation to a male chest? I know the case is not here, but for completion.
Yeah, definitely, sir.
Okay. Dr. Reddy, that's very good. Can you just
Yes.
move a little bit? I know you don't have an indicative case in front of you, but let's say a male chest coming in a similar way. You said that the problem is lack of anterior axillary fold. Could you take me through some of the options that you can help them if a male Poland patient comes to you? Same
Yes.
side, let's say right side, a young male, absence of sternocostal part of the pectoralis major. What are the options that you will have to treat?
Sure. Again, LD muscle can be used for the contour. The second thing we can do is put an implant, the pectoral shaped implants. But there is said to be more complications with the implant as compared to the LD flap. So LD muscle can be used for the treatment.
Why is a problem with the implant-based reconstruction? You
Um,
use an implant in a female, but why is a
yes.
problem in a male? I know males are always a problem, but it's okay. All men are problem. But why using an implant in a male is a problem compared to a female?
Um, so we need a. Okay, I'm not very sure.
Yeah, proceed, Likita. I think you are going in correct direction.
Yes,
What you are thinking seems to be right to me.
so we need a flatter and a larger implant, and the skin envelope might not be as good compared to a female.
Correct.
That's
Correct.
right.
So there is not a skin envelope. Remember, I said earlier on, you need a good quality and good availability of skin to get a final good result, be it a male or a female. So in a male chest with the pectoralis major abscess, if it is tight, you're trying to introduce a silicone implant under the skin under tension. Quite likely you're going to get infection, extrusion, all the problems in related to silicone implant under the skin. So that is one of the problems with that. Okay, let's say this male that you are seeing, you have a look at it, but his posterior axillary fold is not well defined. So he has got a partial atrophy of the LD as well. What else can you offer? His main concern is I want to have better symmetry on the anterior side of that. What else can you offer? You mentioned one technique for the female patient. You can use the same for the male as well. Would you consider fat transfer?
Yes, sir, but we can use the high definition. We can define the axillary fold and the pectoral muscle using a high definition liposuction, and the rest of it we can use a fat transfer.
Why liposuction?
Ma'am, so that the
Aren't we talking of fat transfer?
yes, ma'am. As in, once we transfer the fat, there might be a lot of irregularities. So, only for maintaining the contour on the sides, we can give liposuction for the skin so that it gets more defined onto the chest wall.
Isn't the skin envelope very tight?
Yes, ma'am. We can
I
do it
don't think
directly.
liposuction is the right thing.
Okay.
There is a lack of volume. You're going to put in fat, not take away fat.
Yes.
Yes. Yes, sir.
So unless you have, let's say, the body is in a way that they are a little bit more subcutaneous fat in the axillary area, but not on the chest, then appreciate what you're saying. But
Yes.
by and large, you want to introduce fat to give them an illusion of an anterior axillary fold. And if a
Yes.
patient has enough fat deposit in the abdomen, in the hips and thighs, probably that's the first thing to do compared to using an LD muscle transfer. Once again, it also helps to go with what the patient wants. If the patient wants something that looks firm, like a muscle, then LD transfer will achieve that, but at the expense of posterior axillary fold being compromised. Because you're moving the posterior axillary fold into an anterior axillary fold. So patient has to understand that again, that you're going to lose one to gain something.
And secondly, even the shoulder is going to be weaker if we move the only functioning muscle. So definitely.
So they need to understand that. So sometime if the fat transfer will give them the illusion of having an anterior axillary fold so they can have a t-shirt or a shirt and move on, then that may be a better, less invasive option, although it is multiple sitting. But compared to a female patient, you don't need that many sittings in a male patient. All you're trying to define is the axillary fold. So you may be able to achieve even in 1 or 2 sittings, no more than that, depending on how much of fat you need and that you have.
Yes.
Okay.
Dr. Mehta, as Dr.
Yes.
Mehta said, I would consider the occupation of the patient, because when you
Yes.
take out only functioning abductor, the shoulder, if the LD muscle is there, okay, external rotator, it depends on the person's occupation. Suppose if he's a professional water sports or something like that which he is doing, definitely I would not like to disturb the LD muscle. So I would like to give only camouflage using fat transfer. Dr. Likita,
Yes, sir.
yeah, you have to necessarily ask the occupation of the patient in this case.
Yes.
Okay, because you had asked for a male Poland syndrome, I have asked them to project it, but it's a child only. But anyway, okay, yeah.
Yes.
So, Dr. Bave, anything else that we need to touch upon?
I think she has done very well.
Dr. Reddy, thank you.
Thank you.
Thank you so
Thank
much.